What I'm going to talk about predominantly is a paper that we published in the BMJ a little bit earlier this year, which has been a bit of a labor of love for the past 4 or 5 years, but entirely unrelated to my PhD thesis. So this has been a bit of something on the side, actually. And I can comment about the process of publishing it and about the methodology that we used. And then I'll provide some practical take-home learning points from the conclusions of the paper as well. But I'd just like to thank my co-authors on the paper as well, who were Sam Bampo, who some of you will know I've worked with for quite a long time together, and the late, great David Gilhooly, who it's a real honor to have him recognized posthumously on the paper. BCB, who provided some subject-specific expert input. He's a respiratory and critical care physician from Guildford, and Ramani as well, of course. And I suppose the story started about 4 or 5 years ago when I was one of the first cohort of perioperative medicine fellows at UCLH. And one of the things I got interested in was this, this idea about postoperative complications being a public health crisis, and about their impact not just on short-term outcomes but long-term outcomes. And I got interested in evidence available for reducing organ-specific complications. So we did a scoping review that essentially looked at major society guidelines, major systematic reviews, and Cochrane reviews for organ-specific postoperative complications. And what was interesting is that almost every single organ had major review and major evidence and major guidelines that were reasonably up to date, apart from pulmonary complications, where the last national level guidance publication was more than 10 years out of date. And if you think about the scale of the problem, there's a huge mismatch. And pulmonary complications occur anywhere between 5 to 40%, depending upon the nature of your surgical and patient population. And in fact, apologies for the self-citation, but we found almost 50% of emergency laparotomy patients in 7-day follow-up in London developed a postoperative pulmonary complication. And of course, as you know, they're predictors of short and long-term health outcomes. They're associated with major economic implications for healthcare providers, and they're also associated with adverse mortality. And one of the interesting things about PPCs is that you can think of them, because they're so common, as being a measure of the quality and safety of healthcare that we provide, because they're modifiable clinical adverse events. And the pathophysiology is intrinsically linked with what we do in terms of the way we provide general anesthesia and surgery. So they're iatrogenic injuries, essentially. And that pathophysiological process starts the very moment that you give a general anesthetic and drop the FRC of the patient and start to allow atelectasis to develop. And it's essentially a pathophysiology that takes in contributory factors from 2 pathways. One is around disturbance to the balance of respiratory drive, and the second is disturbance to the balance around those forces that tend to maintain the patency versus collapsibility of airways. And so things like pain and opioids and benzos and long-acting general anesthetic drugs increase sedation, affect swallowing function and upper airway function, and those all have impacts on hyperventilation, aspiration, and worsening atelectasis. And likewise can also affect transpulmonary pressures, cause worsening lung stress and acute lung injury. And things like PEEP and tidal volumes and opioids and even delirium can influence the collapsibility of our airways or patient's airways and promote atelectasis. And what we know is that atelectasis that starts interoperatively has a tendency to get worse during the postoperative period as well. The next thing that's relevant and it's quite interesting is around the role of patient risk factors and procedural risk factors. And by far and away, the most important risk factor for the development of PPCs is the site of the surgical incision. So the closer that surgical incision is to the thorax and the lungs, the more likely you are to develop respiratory dysfunction postoperatively. And then there's some predictable and perhaps slightly less predictable factors that are related to patient risk of PPCs. And the predictable thing is that it's not necessarily the presence of disease, but the functional impairment that occurs as a consequence of disease that's related to risk of developing PPCs postoperatively. So it's not just being a smoker that puts you at increased risk, but whether smoking causes functional impairment in your airways disease. So just being a smoker per se puts your odds ratio at developing a PPC up to about 1.3. So not dramatically higher, but having significant COPD does put your risk up, as does functional impairment as a consequence of cardiac disease. What's slightly less predictable is that age is a really important risk factor for PPCs, irrespective of whether you are healthy or not. So just increasing your age beyond the age of about 60 significantly increases your risk of PPCs. Whereas in contrast, as an independent risk factor for major adverse cardiac events post-surgery, age isn't a particularly important factor. So just being old, even if you're a healthy older person, puts your risk up significantly. And there's a really nice predictive tool for estimating risk of PPCs, called the ARISCAT tool. And the C in the ARISCAT stands for Catalonia because it's a Spanish developed study. And there's 4 patient-specific risk factors, being age or preoperative SAT, whether you had a respiratory infection in the last month, or whether you have a preoperative anemia of 100 grams per litre, or less than 100 grams per litre. And then 3 surgical specific predictors, being the site of the surgical incision, the duration of surgery, and whether it's emergency surgery or not. And what's quite nice about that is that most of those factors are things that you can either have or estimate preoperatively. So there's a basic tool that gives you a reasonable preoperative risk assessment for PPCs. And that risk tool's been subsequently validated in a 5,500 patient cohort across centers across Europe. And that's the best tool that we have for predicting PPCs preoperatively. Of course, the prevalence of PPCs depends on how you define PPCs, and that's a matter of contention over the last 20, 30 years. And in fact, it's taken until 2015 for a consensus definition of PPCs to emerge. And that came from the European Society of Intensive Care that defined PPCs as being respiratory infection, respiratory failure, pleural effusion, atelectasis, and pneumothorax. And what's slightly interesting about that definition, and slightly controversial, I think, is that some of those endpoints are complications that may well occur in the lungs, but aren't necessarily related to lung pathology per se, like pleural effusions, which may be all related to cardiac failure, for example. There's also no grading of severity included in those definitions either, which is a problem. Some of which were resolved in the later standardizing endpoints group review that produced some slightly more refined definitions as well a couple of years later. But for the purposes of our paper, because we started around 2015, 2016, we used the EPCO definitions for the review rather than the step ones. And so this brings me to the research question that we asked as part of our review, which was essentially to update the previous systematic review that looked at all source evidence for efficacy of interventions to prevent postoperative complications, and to improve that and to ask the question, what is the best quality evidence for efficacy of treatments to reduce ppcs? And there was some slightly interesting approaches that we necessarily had to take as a consequence of adopting this question, which you wouldn't necessarily do for some systematic reviews. And that is that we asked a very broad question that took in a very broad cohort of patients and a very broad cohort or group of interventions, but only a single outcome measure, a composite outcome measure in this case. Whereas often what you will do with a systematic review is to ask a question that takes in a very defined population, a very defined intervention, a very defined control group, and a very broad group of outcome measures. So we took the opposite approach. And what was necessary as part of that is that we had to just look at treatment effects, because of course the different interventions will have different adverse effects which aren't necessarily comparable. So we looked at efficacy, treatment, and what we did was compare the quality, quantity, and risk of bias as evidence from those randomized trials. So this doesn't answer everything that you would want to know in order to determine best practice, but it's a significant step forward in terms of summarizing the overall evidence base for a really important clinical problem. And so our methodology was to do a review from multiple different sources, and then use meta-analysis techniques as well as trial sequential analysis techniques, and then use the grade system for assessing quality of evidence. So we adopted the majority of the Cochrane group review methods. And the grade system, if you're aware of it, it's essentially an objective way of rating quality of evidence based on risk of bias of randomized trials. So one person should be able to come up with the same quality of evidence assessment as another does. And that quality of assessment is quite stringent. So a randomized trial with low risk of bias is high quality evidence, but only having one factor on your risk of bias assessment that would increase your wariness around risk of bias is enough to downgrade the evidence for that particular trial. And then when you compute or amalgamate the evidence from multiple different trials to reach a final outcome assessment, then actually if you have a few small discrepancies on individual trials, it could be enough to downgrade your quality of evidence. So it's quite a stringent evidence assessment tool. And just for interest, that's the search strategy that we used. So we looked at trials predominantly taking in what we thought would be contemporary surgical practice. So a lot of laparoscopic surgery, actually. So from 1990 onwards. As it turns out, the majority of the trials were open surgery. So I think it was only about 15% of trials which were laparoscopic. And only randomized studies. And as you know, a lot of these interventions are very difficult to study in randomized trial design, which does mean that we did omit some evidence from propensity match studies and observational studies, which I'll comment on in the conclusions of this talk as well. And there's always one table or chart in a paper that's the most important table or chart, and this is the table from our paper that's most important. So this is essentially a summary of individual meta-analyses of over 120 randomized trials covering more than 20,000 patients, looking at treatment effects of different interventions. So you can see that enhanced recovery after surgery protocols had the largest intervention effect, and then various different interventions running through to things like incentive spirometry that showed no different treatment effect. And what I'll do is I'll just drill down a little bit more into the detail for what those individual meta-analysis tables mean. But the first thing to comment about is actually what a meta-analysis is and why we do it. And if you think about measuring a fixed entity with a specific measurement tool that that isn't biased, so it doesn't systematically under or overread the measurements. They're considered something like acceleration under gravity. Then what you will see if you take multiple measurements with that one tool is that you'll get a scatter of results around a true value or a mean. But what if you use different measurement tools to measure that same fixed entity? Now, each of those measurement tools will have a noise attributed to it, or a different precision of the tool. And what that means is you can't necessarily then simply pool the means. So meta-analysis is a way of pooling that data and weighting it according to how likely or not the data is to represent the true value. And the standard approach is to do something called inverse variance. So variance is a measure of the deviation of data around a middle point or mean point. So the more the variance, the lower the weighting. So the more scattered the data is, the less precision there is in the data from that particular measurement tool, the less we put a weighting on that trial in the meta-analysis. But there's a number of slightly more sophisticated ways of doing it as well, which is use things like fixed and random effect models. And a fixed effect model makes the assumption that basically all the outcomes, patients, and interventions for all the trials in a meta-analysis are the same, or at least very, very similar. So what you are measuring that's different between the trials is a difference in that noise, or the difference in that measurement method. And so the true effect is the same in all the studies. A random effect model makes the assumption that the true effect varies between trials, and what you may be measuring is something that's different in terms of the patient cohort. So an intervention may have more effect in an older population than in a younger population, for example, or a population that received the intervention for a week rather than 2 days. So the studies included in a meta-analysis in a random effects models is assumed to be a random sample of the relative distribution of all the effects. And so the combined effect estimates the mean effect of all that distribution. So what this means essentially is that a fixed effect model weighs the study based entirely on the amount of information that's present in the study. So a large study gets the lion's share of the weighting, and a small study gets almost ignored. In contrast, the random effect model weights the studies more evenly. So you accept that large studies are more likely to yield more precise estimates than small studies, but the weights assigned are more balanced, and you're less likely to trivialize smaller studies. The other bottom line is that you're more likely to get more conservative significant estimates from random effects models. And in practical terms, if you've got high heterogeneity in your pooled data, then you're more likely to choose to use a random effects model because it handles that heterogeneity better and gives you a more conservative estimate of statistical significance. In this review, because we accepted that we were using a broad population and broad set of outcomes, we actually chose random effects modeling for everything to give us the best estimate or the most conservative estimate that we could of statistical significance. The second approach that we used is something called trial sequential analysis, which has been around for about 10 years now, and is essentially a way of overcoming the tendency for conventional meta-analysis to overestimate type 1 and type 2 error. So you're more likely to have a type 1 or type 2 error in a conventional meta-analysis than you are when you use a trial sequential analysis. And it's a different philosophical approach in a way to designing a meta-analysis. And essentially what a trial sequential analysis does is consider each individual addition to the meta-analysis. So each randomized trial that you add into the meta-analysis to be a different interim analysis. And therefore, it adjusts the confidence intervals for significance for the fact that you're essentially doing multiple significance testing. If you were to do an interim analysis on a single randomized control trial partway through, which is often done, then your risk of type 1 and type 2 error is high because you've not reached your predefined sample size. And the same thing could be said of a meta-analysis. And what trial sequential analysis does is allow you to estimate a power calculation, essentially, for a particular meta-analysis as well. So you can predefine an effect size, and then using the pooled data that you have in meta-analysis already, you can use a TSA to estimate how much more data you would need to be confident about that particular effect size with a given alpha and beta values, or whether you've gathered sufficient what's called diversity adjusted required information size, whether you've gathered enough information to be confident about that effect, pooled effect as well. And that's what we did for this study. What's interesting is that the Cochrane group, or at least their most recent statement on TSA, was that they've decided not to adopt it for their Cochrane reviews, despite a number of papers published that have reanalyzed Cochrane review data using TSA approaches and found significantly different conclusions. And I think that part of the reason for that is a desire to avoid over-reliance on statistical significance as a defining conclusion for Cochrane reviews, and rather a weighting on the clinical importance of relative effects. And as you know, if you have a very large sample size for any trial or meta-analysis, you're far more likely to have a significant pooled effect, even if that actual treatment effect is not particularly clinically significant. So it could be a very small effect, which is of very little clinical relevance, but still reaches statistical significance. And so I think part of the Cochrane review, Cochrane group's thinking is to avoid that interpretation. And the second is that because you can define a sample size with TSA, you might reach a conclusion that sufficient information has been acquired to reach a definitive conclusion, and therefore no further trials are required. Now, Cochrane reviews do make those conclusions, but I think the Cochrane group's fear is that TSA will be used for the primary analysis and not secondary analyses, or not secondary outcomes. And those secondary outcomes can be really important for subsequent meta-analyses as well. And so they've, for the time being at least, they've decided against using a TSA approach in their trials. So this is one of the individual meta-analyses from the review, and the supplementary data has actually got a summary of all the 120 randomized trials, as well as individual forest plots and funnel plots for all of the individual meta-analyses that fed into that master forest plot you saw on the previous slide. So I'm just going to point a couple of things out. So the first two studies, dating from 91 and 96 by Hall, had very large sample sizes, nearly 900 patients in the first one, and nearly 500 in the second trial. And there are 6 different trials in this group. And almost all of the trials have got a risk ratio that's very close to 1, so very small effects. And they all have confidence intervals that cross 1 as well. And so unsurprisingly, the pooled estimate, the overall effect, which is the Z value, is very close to 1, and the p-value for that in conventional meta-analysis is 0.95, so there's no statistical significance. Now I'm going to show you a trial sequential analysis plot for that same conventional meta-analysis to show you how it works, essentially. And I also put all of the TSA plots into the supplementary data for the paper, as well as an explanation for interpreting each of these TSA plots as well. So if you're interested, have a look at the paper, and it's all explained there. So this is a trial sequential analysis plot. And for this particular analysis, what I predefined was a 25% relative reduction in risk with an alpha of 5% and a power of 80%. And I calculated a required information size of just over 3,000 patients that was required to reach a firm conclusion for the data set. And what you can see in the middle is the Z value, essentially, so the overall pooled treatment effect. And then either side of those Z values are two brown lines, which are the conventional monitoring boundaries. So those brown lines are essentially where a conventional meta-analysis, like the Cochrane group uses, would reach statistical significance. So if the blue line crosses that brown line, that's when a conventional meta-analysis would declare a p-value of less than 0.05. The red line are the adjusted confidence intervals. So as you can see, the more patients or the more data is added into the analysis, the tighter those adjusted confidence intervals get, and the closer they get to the conventional monitoring boundaries. And indeed, if we were to track this all the way to the required information size, that red line would meet the brown line, and the same, you would reach the same statistical conclusion. On this plot, the x-axis is essentially the timeline and number of patients in each of the randomized trials. So the first trial was large, it was 900 patients. So we've increased our information size by 900 patients worth of data, and the second one by about 500. So that's why there's a big jump between those two black points on the blue line. And then each of the subsequent 4 studies are relatively smaller. And that Z-curve number is slightly obscure, but that's 1,940. That's the total number of patients. So the trial sequential analysis doesn't cross either the conventional monitoring boundaries, it doesn't cross the adjusted confidence intervals, nor does it cross the required information size. So we reach the same conclusion that the conventional meta-analysis does, which is to say there's no statistically significant difference between the experimental and control groups. In contrast, this is a trial sequential analysis plot for goal-directed fluid therapy for reducing postoperative pulmonary complications. So as you can see, there's a sequence of smaller studies and then several large studies. And what's interesting here is that at the point of the second study, the conventional monitoring boundary is crossed. And this highlights one of the risks of using conventional meta-analysis technique, which is that with sparse data particularly, you're far more likely to overestimate treatment effects. So if you use the Cochrane group's meta-analysis techniques, even using a random effects model rather than a fixed effects model, then the conclusion, if you were to just use 2 trials in the meta-analysis, which I know sounds laughable, but you do see Cochrane reviews with 2 or 3 trials as part of the meta-analysis, then the conclusion would be that there was a statistically significant difference between the treatment and effect and control groups. And as we can see on the trial sequential analysis, we're not even close to the diversity adjusted confidence intervals. They're not even plotted on the graph. So using a TSA group, we would reject that conclusion. However, as we add data into the trial sequential analysis, we cross the red line, which is our adjusted confidence interval, even though we don't cross the required information size, which again was about 3,000 patients in this group, we're 500 short, but we've crossed our adjusted confidence intervals. So we reached a conclusion that there is a significant difference between the 2 groups. Does that make sense? So, as I say, we involved almost 120 trials with 22,000 participants. We categorized 11 different categories of intervention, which were sufficiently similar that we could pull the results from the trials together. Majority of the evidence is low quality. We did find 7 interventions with low and moderate quality of evidence of benefit. And when we did the trial sequential analysis, we found significant benefit for prophylactic respiratory physiotherapy, epidural analgesia, ERAS, and dual-directed fluid therapies. So I'm just going to jump a little bit ahead from the paper now and synthesize some take-home learning points in terms of how you can adjust your anesthetics to reduce the risk of PPCs for your patients. And I call these PEETS 5 Ps for preventing postoperative pulmonary problems on the perioperative pathway. And those 5 Ps are to predict the risk of PPCs, to optimize patients, to prevent PPCs from happening, to protect your patients for developing PPCs, and then finally to participate in future trials. And I'll just summarize quite quickly in the last 5–10 minutes some of my thoughts and conclusions about this pretty wide evidence base. So the first thing to say is that, as I've already mentioned, there is an extremely well validated risk prediction tool for PPCs called the ARISCAT tool. It makes sense to do preoperative risk evaluation. However, there are currently no evidence that just risk stratifying for risk of PPCs prevents PPCs postoperatively. For much of the risk, that's true for much of the risk, preoperative risk stratification evidence base, with the exception of NELA perhaps. And some of those biggest risk factors are age over 50, BMI over 40, ASA of 2 and above, obstructive sleep apnea, preoperative anemia, preoperative hypoxemia, emergency and urgent surgery, a ventilation duration of more than 2 hours, and then several saturations intraoperatively and cardiovascular impairment. So the OPtimise side of things. So I think probably the most promising area is this idea of prehabilitation. And that's becoming very popular, not just for preventing pulmonary complications, but preventing all types of postoperative complications. And there is some supportive evidence from some small trials for inspiratory muscle training, and that's the conclusion we reach from our review as well. But to date, there are yet to be any large-scale pragmatic studies of inspiratory muscle training. And thankfully, Denny Levitt from Southampton is in the process of setting up a big pragmatic study called the INSPIRE trial, which is looking at inspiratory muscle training. I think that's probably one of the most promising prospects today. And of course, inspiratory muscle training is a very inexpensive intervention, and it's something that you can do at a patient's own home. It's usually done with an incentive spirometer, which is a little device that provides resistance to exhalation. And we know from the review data, as one of the meta-analyses I've just showed you, that actually post-operative incentive spirometry, despite it being very popular with surgeons, actually doesn't have any evidence of benefit. And I think there's probably an attrition factor in that, and that I think it's probably very poorly used, and it's also probably a bit late too. I think it's trying to catch the horse after it's bolted. But pre-operative training, I think, has got relatively more promising prospects. We know that major surgery is a teachable moment for patients, and that lifestyle interventions are more likely to be accepted around that time, and certainly cessation of smoking is an interesting one. So stopping smoking definitely does reduce your risk of post-op pulmonary complications, and that contention that stopping smoking increases respiratory secretions, which increases your risk of atelectasis post-op, has been refuted subsequently. I think the big question is when to stop it, though. Stopping at 8 weeks probably reduces your risk by about half as much, or by about twice as much as stopping at 4 weeks. Whether or not there's any benefit to stopping at less than 2 weeks is contentious. And actually the randomized trial evidence for smoking cessation is very, very poor. And most of the studies were largely done in low risk patients. Yeah, it's still an important intervention. Medical management with respiratory comorbidity has got a lot of logical rationale, but little empirical evidence, and certainly prophylactic use of things like magnesium and beta agonists to improve respiratory function has got no evidence of benefit in randomized trials, and there's very little evidence of actual in longitudinal studies as well, but certainly makes sense. Whether or not correcting preoperative anemia, which is well recognized as an important risk factor, actually reduces the risk of PPCs is also questionable. But certainly having an anemia preoperatively puts you at risk. But whether or not that reflects deranged homeostatic measures and frailty, which isn't necessarily corrected for simply by increasing your hemoglobin concentration, is still unknown. I think where things get really interesting for anaesthetists is the prevent stage. And I think one of the most appealing prospects is that we can dial up slightly different numbers on our ventilators at zero cost and reduce the risk of pulmonary complications. And there's little doubt that we can improve respiratory function intraoperatively by dialing up those correct settings on the ventilator. But I think the big question is how long do those benefits last post-operatively? Having said all that, there's now 4 meta-analyses, including the one we published, that support intraoperative ventilation, or intraoperative lung protection ventilation for major surgical patients. And there's also a consensus statement paper, which I put the reference on the slide for there, which is interesting in its relevance. What's also interesting is that large-scale audits of practice show that we don't do this very well. Despite it being an evidence of benefit, which costs nothing to the healthcare provider and involves very little evidence for the clinician, we don't practice lung protective ventilation particularly well intraoperatively. There's several major trials, which I'll just quickly summarize. So the first major trial was the Previllo study, which was 900 patients that pitted 12 centimeters of PEEP against 2 centimeters of PEEP intraoperatively for tidal volumes of 7 mils per kilo in both groups for major surgery patients, and found no difference in risk of pulmonary complications, but a higher incidence of cardiovascular complications in the 12 centimeter PEEP group. And I think most people would agree that those are relatively extreme values, and that's probably got something to do with the conclusion of that study. So the second biggest study is the IMPROVE trial, which again was a double-blinded, multi-center randomized trial of about 400 patients with 6 to 8 mils per kilo tidal volumes, and then PEEP values of 6 to 8 centimeters in one group with recruitment maneuvers versus 10 to 12 mils per kilo tidal volumes with no PEEP and no recruitment maneuvers in the opposing group, and found a decreased risk of pulmonary complications, especially respiratory infection. Well, those were very large tidal volumes for the control group, and again with no PEEP in that control group. And what these two trials illustrate, I think, is a big problem in mediating or find a synthesis for the evidence in this group, which is that a lot of the studies combine both PEEP and tidal volumes in the intervention and control group. So it can be quite difficult to tease out which is the beneficial intervention. Although there are a small number of studies that have looked at equivalent PEEP values and just differences in tidal volume and found differences in pulmonary complications. So it's likely that, that tidal volumes are relatively more important than PEEP. And there's a logical train of thought, I think, that follows on from the great fluid debate, which is that having too much or too little of any one thing is bad, and somewhere in the middle, and probably being individualized is probably the right value. And there's a really interesting study that was published in the Lancet Respiratory Medicine called iProve from a Spanish group 2 years ago that took exactly that approach. So they had 4 groups in the trial, and they randomized essentially to different levels of individualization of PEEP during the intraoperative and immediate postoperative periods. So one group had intraoperative PEEP that was individualized to dynamic lung compliance, and then had CPAP applied postoperatively with, again, an individualized PEEP value, stepping down to the final group, which had a standardized PEEP and just humidified oxygen postoperatively rather than CPAP. What they called an open lung approach for lung protection. And rather frustratingly, found no difference between any of the groups in terms of pulmonary outcomes. But they were relatively small group sizes, and all of the groups had some form of PEEP and some form of moderate tidal volumes. So I think the conclusion to take, or at least my personal take on it, is that extreme values in any form are bad. Certainly 0 PEEP is bad. A moderate value of about 6 to 8 centimeters of PEEP is probably around the right value for most. And extreme tidal volumes are also bad. And probably adopting the same approach that, you know, we've got very good evidence from the ARDSNet studies for acute lung injury in intensive care patients. 6 to 8 mils per kilo is about the right values to opt for. There'll be a lot of patients in whom these kind of approaches make little to no difference. I think probably for most young, fit and healthy lungs having short minor surgery, it probably makes little difference how you ventilate them intraoperatively. But for those having prolonged surgery and for those at preoperative high risk, I think there's convincing evidence that we can make a difference. And like I say, it's a difference that costs nothing as well, except a little bit of thought around how you're going to ventilate. And of course, there's a lot of other interventions for intraoperative ventilation that make a lot of intuitive sense, even if there isn't a huge amount of empirical evidence for supporting them. Things like avoiding 100% oxygen immediately prior to extubation, which I know is a very common practice because that promotes atelectasis at the very moment that you want to avoid it the most. Things like doing recruitment maneuvers using the ventilator rather than switching to the bag to do it, because that promotes a loss of PEEP and loss of de-recruitment of the lungs. Things like avoiding apneic periods to build up CO2 immediately prior to extubation, because again, that causes airway collapse. And I mean, this is a whole separate lecture, to be honest, but so I'll leave that there for now. Just quickly summarize a few other points. So epidural analgesia does have low quality evidence of benefit in preventing pulmonary complications. The majority of the evidence comes from the big master study run in Australia that looked at major GI surgery and epidural analgesia. And of course, that's around quality of postoperative analgesia and avoiding respiratory muscle dysfunction. Goal-directed fluid therapy's got moderate quality evidence, but quite a small effect size. Your number needed to treat is about 50 to 60 to prevent a postoperative pulmonary complication. What's also really interesting for anaesthetists is that we've got very good evidence from observational studies that having inadequate neuromuscular blocking drug reversal is associated with pulmonary complications. And in fact, having a train of 4 prior to extubation of less than 0.7 is definitely associated with pulmonary complications. And even less than 0.9, which is pretty much clinically indistinguishable from normal reversal, is associated with a risk of increased pulmonary complications. And therefore, you would think that using high quality reversal like Sagamodex would be superior to neostigmine. And unfortunately, there's 4 different randomized trials of Sagamodex versus neostigmine, none of which have shown any difference in pulmonary complications. Although there is good observational study data from about 60,000 patients that there is a difference, just not in randomized trials just yet. And so protecting patients. So physiotherapy is another area where practice doesn't quite match up with the strength of evidence from randomized trials. And interestingly enough, there aren't any national guidelines on preoperative respiratory physiotherapy, but physiotherapy and early ambulation are really important components of enhanced recovery after major surgery, which does have evidence of benefit. And there've been about 12 studies over the past 20 years, mostly small trials without any significant difference, but a couple of the newer studies that have incorporated preoperative physiotherapy, doing things like the inspiratory muscle training, have cast a more optimistic light. Intensive spirometry we've already covered, and certainly post-operative intensive spirometry alone certainly does not prevent PPCs. And enhanced recovery, especially things like early mobilization and avoidance of NG tubes, does. The PRISM study by Rupert Pearce has recruited more than 4,000 patients for post-operative CPAP, and I think probably offers the best prospects for indicating whether or not post-op CPAP does have benefit for high-risk patients. There's been a few studies, mainly from Australia and New Zealand, that have looked at high-flow nasal cannula oxygen post-operatively, which haven't shown any benefit in reducing PPCs, interestingly. And then finally, participate. So there's a lot of good evidence that combining a number of outcomes into a bundle of care can have synergistic effects and also be used as a QI tool for monitoring compliance. And of course, we've got bundles of care for preventing pulmonary complications in intensive care patients that are very well evidenced, but none yet for intraoperative care. There's been a couple that have been trialed in longitudinal studies, one from a group in Massachusetts and another from a group in Manchester, which probably haven't had the right study design to show benefit, or weren't choosing the right interventions. But we think that there's good translatable evidence that that this should be a candidate for future trial design. And in fact, until COVID stepped in, this was the plan, which was to take the evidence that we synthesized from this review and use some adaptive trial design embedded within PQIP to run a randomized study looking at a care bundle for preventing postoperative pulmonary complications. And that still is the plan, but it's just been put on hold a little bit by COVID. And as I've already talked about, there are a few other major randomized trials that are coming in the next couple of years as well. So just to summarize, like most things in medicine, the solution to preventing pulmonary complications takes a lot of people working across a lot of different disciplines, doing something together in a coordinated way. But we, as anaesthetists and perioperative physicians, have got a really important role to play within that, particularly around intraoperative ventilatory practice. The paper that we published in the BMJ is actually double the length of a normal review. So it's almost 9,000 words, and it's got a supplementary data paper that's that covers pretty much everything that isn't covered in the main review paper as well. So have a read of that if you're interested in anything that I've talked about. And think about Pete's 5 Ps, which are predict, optimize, prevent, protect, participate. And thank you very much for listening. And I'm very happy to field any other questions as well.